Yeah. Good morning, everyone. And today, Dhruv will be presenting the case and moderated by Professor Anshuman Pandey, Professor Saumitra Rawat, and Professor Sadaf Ali, Madam. It's all yours, Dr. Rawat and Pandey, and Madam, you can take over now.
Good morning, everyone. Today I'm presenting a case of a 58-year-old male from Jharkhand who's a coal miner by occupation. He has chief complaints of worsening of bleeding per rectum for 45 days and easy fatigability for 45 days. His history of presenting illness, the patient was apparently normal 10 years back when he started having multiple episodes of small quantity intermittent bleeding per rectum episodes mixed with the stool 2 to 3 times per week, which was dark red in color and not associated with painful defecation. I'd further like to know about the stool frequency and the quantity of stools he's passing. He has an history of occasional mucoid discharge.
Dhruv, can you go on to the slideshow?
Yes, sir. He has, wait, I'm having some difficulty reading my full slide in this view, sir. Not able to.
You're not able to read? Yeah,
Yes,
okay,
sir.
go ahead.
1 minute, I'll have to change some settings. I think
Okay, go
now
ahead.
it will be possible.
Uh,
Yes, sir. Patient was apparently normal 10 years back when he started having multiple episodes of small quantity, intermittent bleeding per rectum, mixed with stools. These episodes were around 2 to 3 times per week and were dark red in color and was not associated with painful defecation. Here, further like to inquire about the stool frequency and the quantity of stools he's passing. And there's history of occasional mucoid discharge, but how often it was there and was it mixed with stools or sometimes mucoid discharge was there without stool also, that I'd like to know. With no foul smell in stool. The patient did not seek any medical help for the same. Now he has a history of recent increase in frequency of bleeding per rectum for last 1.5 months, with bleeding episodes daily once or twice, which has increased from 2 to 3 times per week to once or twice daily. And it is still not associated with pain or change in character of bowel habits. I'd like to know about the quantity of the blood. Has it increased from previously? And is there any change in color of the blood he's passing? And the change in mucoid discharge. He also has complaints of easy fatigability and weakness for 45 days, which was interfering with his daily activities. Also, I'd like to know if he had any sudden episode of postural dizziness or syncope, or was this a gradual onset of weakness for him? There is no history of constipation, loose stools, fever, change in caliber of stools, perianal discharge or mass per rectum, no abdominal pain, no abdominal distension and vomiting, no loss of weight, loss of appetite, no tenesmus or spurious diarrhea, no jaundice, bone pain, chest pain, breathlessness or hemoptysis, no eye symptoms, redness of eyes, joint pain or skin lesions. The patient was evaluated elsewhere with blood investigations, endoscopy and colonoscopy, following which he received 1 unit of blood transfusion and was referred to a higher center for further management. I'd like to know if any procedure was done during this endoscopy time. In past history, there are no similar complaints in the past, no known medical comorbidities, no history of previous surgeries, no history of any drug use. In personal history, sleep is disturbed. He has mixed diet. Bladder habits are normal. I'll further like to inquire about his bowel habits and addiction. He's chronic tobacco chewer for 15 years. I'd like to know the quantity of the tobacco he's consuming, and chronic alcoholic since 20 years. Again, I'd like to inquire about the quantity and his reason for stopping since 1 month. Family history, there's nil significant family history. So to summarize, my patient, a 58-year-old male coal miner from Jharkhand with no comorbid illness, had intermittent painless bleeding PR of small quantity and dark red colored blood, not associated with diarrhea or constipation and not requiring any urgent medical attention for 10 years, has worsening of the painless bleeding PR for 45 days with increase in frequency to 1 to 2 times per day from 2 to 3 times per week, with associated weakness and easy fatigability and requirement of 1 unit of blood transfusion. The differentials I like to keep here are vascular ectasias or angiodysplasias, colonic polyp, hemorrhoids, diverticular disease, inflammatory bowel disease, or rectal varices or portal colopathy.
Yes, doctor, you made a summary with presentation. I just wanted to make a point over here.
Yes,
In
ma'am.
history taking, you said somewhere that there is no history of mass per rectum. It's not a
Yes.
very common presenting symptom. Patients usually don't come with saying that I have a mass or I don't have a mass. Okay.
Okay, ma'am.
Yeah,
Okay.
I think you should, if everybody agrees, you should omit such statements. Okay, why did you put your IBD so low in your differential diagnosis? Your reasons?
Ma'am, patient doesn't have any diarrhea or any other symptoms. And for 10 years without any treatment, there is no worsening and there is no other issues with the patient, no systemic signs of the disease and no anemia and no diarrhea especially. So I thought IBD, I'll keep it lower down in the differentials.
Dhruv, why did you put angiodysplasia as your first?
Sir,
Because I'll be very
Yes.
honest with you,
Yes,
I'm
sir.
very concerned about you putting vascular ectasia and angiodysplasia as your first differential diagnosis.
Yes, sir.
How
Sir,
often do you see?
yes, sir. Not seen, sir. I have personally
So
not
why
seen.
you have put first? This is what irritates the examiner. You know, just after presenting your history, you have put vascular ectasia and angiodysplasia as your first differential diagnosis. If you would have put colorectal cancer, I would have accepted it. But you know, putting vascular ectasia and angiodysplasia as your first, I just can't swallow.
I thought, sir, the patient is having history for 10 years and small quantity only intermittent bleed. So for such a long time, so I thought maybe it's only vascular dysplasia and angiodysplasias can have only minor bleed, which will not be bothersome, and it can also with time increase to a more severe bleed, as these are minor venous bleeds initially, and later because of the progression of the malformation can have increase in the bleeding. So I thought, because main was concern was that patient is having a long history of 10 years and it is maroon red, dark red colored blood. So I thought more likely from a right-sided colonic lesion, this blood should come. So that was the reason for keeping it on the top, sir, in this case.
So, Dhruv, I'll ask you a question.
Yes, sir.
Regarding this vascular ectasia, I also agree that it should not be the first differential. Since there was a long history, 10 years, would you like to elaborate something whereby there was a waxing and waning of symptoms in between? What actually exacerbated or increased the symptoms? And number two, he only had 1 unit of blood transfusion. So we agree that there was no significant blood loss or easy fatigability or anemia. So your right-sided colon also, which is usually presenting as, anemia, also in cases of silent presentation would be there. What about the differential diagnosis of Indian scenario? What about tuberculosis? What about any kind of typhoid ulcers? A recurrent person living in periphery having an inflammatory or an infective disorder. Why don't you consider all these things which are relatively more common?
Sir, history of 10 years, sir, was the main factor I didn't consider for infectious etiologies, because patient should have had
This
wasting,
is
some
what I want
kind
to
of
say that
loss of weight.
this is what I want to say that 10 years history is a very long duration. So
Yes.
are we missing out something in the history?
Yes, sir. Maybe there could have been further episodes and
Okay. Another thing, you said something about hemorrhoids as your third differential. Please
yes.
elaborate. How does an hemorrhoid present, and why do you consider it higher than your, say, a diverticular disease or maybe any kind of constipation associated with or any kind of infective pathology?
Sir, diverticular disease usually will present with massive bleed. although it will spontaneously, but the bleeding episode will be massive at that time. So it won't be small quantity intermittent bleed for going for 10 years. So I kept diverticular disease below it. Hemorrhoids also, although it should have been a bright red blooded, but bright red blood and should be with along with stools, and there will be a spurt in pan during a hemorrhoidal bleed. But I thought maybe there's some issue with the patient reporting the color as dark red, and it could have been an hemorrhoidal bleed. And it will not be mixed with stool; it will be separate from the stools, hemorrhoidal bleed.
So I agree that you would need some kind of an evaluation. But before that, in history component, you should elaborate on certain things regarding the family history also. What do you think are you missing out in the family history?
So family history, well, if there's a history of any malignancy or polyposis in the family, or tuberculosis also, if there's any case history of TB in the family. So,
Okay. So would you like to change your differential diagnosis at this point in time?
sir, I'll like to add, sir, maybe ileocecal TB in the differentials, and hemorrhage push it down a little bit more in the differentials.
No, you
Angio
cannot be vague. What is your number 1, 2, 3? Maybe we'll not be bothered about 4, 5, 6, but what is your 1, 2, and 3?
Number one, sir, then I'll like to keep colonic polyps as number one, sir. Maybe second, ileocecal TB. Third, angiodysplasia. Fourth, diverticular disease. And fifth, hemorrhoids. Sixth, IBD.
So IBD would be your 6th. I don't know whether the panelists would agree with it.
No,
I won't agree with him because Dr. Dhruv, in your clinical practice, you usually come across what common kind of colorectal diseases
Sir,
with such symptoms. Why don't you put CA colon as a differential diagnosis?
10-year history was the main concern for me. Maybe it's a polyp which has now degenerated into malignancy, but for 10 years, a patient having a malignancy without any other symptoms.
but then Dhruv, if it is a polyp, how much time does it take polyp to become malignant?
So 10 years, it can take, sir, around 10 years.
Mhm. And the polyp will start bleeding on day one.
No, sir.
So don't use vague kind of terms.
Yes, sir.
See, it can be a combination of problems. There are so many patients who walk into our OPDs with bleeding PR with common causes to it. So if you said that you wanted some points in history which you don't have an access to. So if you had some access to history, would it change a little bit? Because it will not, you don't have to wait for conversion, but there can be, anybody can have past history of bleeding PR infrequently once every 2 or 3 years, and now there can be history of malignancy. Then the mucus is also very important for your IBD to be differential. Like these are the common things which we see beyond hemorrhoids as a 10 years history that somebody would have picked it up by now.
Yes.
Anyway, Dhruv, this is just to emphasize that something like angiodysplasia putting as a first diagnosis and polyp putting as a first diagnosis, when you are going for the exam, you need to start justifying and put the common thing first. Don't go
Yes.
for, something like polyp as your first diagnosis. Otherwise, examiner will think that, there might be that you may know the case, or if you start putting an angiodysplasia, he will certainly think that, you have been told that the patient has got an angiodysplasia. Put
Yes, sir.
common thing first. Like we said, 1, 2, 3, these kind of thing will come 4, 5, 6.
Okay, sir. Yes, sir.
And in differential diagnosis, if you would have put colorectal cancer as the first, And in your justification, you could have said that, patient may have had a polyp, and now it looks like, because the symptoms are worse in last 45 days. This is what I'm saying. So it can used as a justification, but putting first diagnosis as a angiodysplasia or first diagnosis as a polyp, no. Okay.
Yes, sir. Yes, sir.
So do you want to carry on with your examination?
Yes, sir.
I think he should change his differential first. So please tell us 1, 2, 3. What are your differentials?
So, a colorectal malignancy as first, sir, and inflammatory bowel disease as a second differential. Third, I like to keep then ileocecal tuberculosis, and then maybe fourth angiodysplasia, and further diverticular disease as fifth.
So a 58-year-old gentleman from Jharkhand, maybe from periphery, you may have a missed history component whereby these symptoms have exacerbated or increased in the recent times. And then subsequently, you may have a colorectal malignancy also. Although your history seems that it is pretty, long, of a very long duration, there might be something missing in the history. Maybe the sequence could be colorectal malignancy as a lower one, but you have included 2 differentials which were not there. Maybe you can carry on now.
Yes, yes. On general physical examination, the patient's conscious, cooperative, and well-oriented. He is moderately built and nourished with a performance status of 1. His height is 1.64 meters, weight 65 kgs, and BMI of 24.1. He is having tachycardia with pulse of 98 per minute and a BP of 114 by 74 mm of mercury. I like to know if there's any orthostatic hypotension or increase in pulse rate on standing BP if it has been checked. Respiratory rate 15 per minute, and he's afebrile. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. No left supraclavicular lymphadenopathy. On examination of the abdomen is flat, umbilicus is central and inverted. All quadrants are moving equally with respiration. No scars, engorged veins, visible peristalsis or visible pulsations. No renal angle fullness, hernial orifices, no visible cuff impulse. External genitalia is normal. Palpation soft, non-tender, liver and spleen are not enlarged. No other lump palpable. Hernial sites are normal. On percussion, liver dullness is in the 5th intercostal space. Liver span is 13 centimeter in mid-clavicular line. The flanks are tympanic. There are normal bowel sounds heard. If any bruit was there or not, I like to know. And on digital rectal examination, the perianal skin is normal. No evidence of fissure, fistula, external hemorrhoids. Normal sphincter tone, no palpable mass. A glove stained with yellow stools, and proctoscopy, normal rectal mucosa with no evidence of inflammation. So after my the respiratory system is normal, CVS and CNS also are normal. So after the examination, the patient, a 58-year-old male coal miner from Jharkhand with no comorbid illness and ECOG1, had intermittent planeless bleeding PR of small quantity and dark red colored blood, not associated with diarrhea or constipation and not requiring any urgent medical attention for 10 years. Has worsening of the painless bleeding per rectum for 45 days with increase in frequency to 1 to 2 times per day from 2 to 3 times per week with associated weakness and easy fatigability with requirement of 1 unit of blood transfusion. His BMI is 24.1 and has tachycardia on examination with no significant abdominal or perrectal findings. So the differentials I like to keep here are number 1 as colorectal malignancy, then ileocecal tuberculosis as 1, colorectal malignancy, third as angiodysplasia, fourth diverticular disease, and fifth maybe IBD, Crohn's disease.
There seem to be many questions regarding your sequence of differentials, and people are calling it very strange too. So maybe they're right in those scenarios. Please tell us, you don't have any finding apparently according to you. So
Yes,
please
sir.
summarize your finding. What are your positive findings?
So tachycardia was there, sir, and patient is BMI is 24.1, so he seems well preserved. So any chronic disease, tuberculosis would have caused certain amount of wasting by now if it was a 10 years history in the patient. And This tachycardia, so he might, it is either because of the anemia he's having, or he's still bleeding actively. Currently, when he has presented, he's still having some bleeding.
So tell me something. What are the signs you say of active bleeding?
Patient, sir, will have tachycardia, sir. Per rectal, there should have been blood on examination, but there is only yellow colored stools on examination. But a tachycardia will be a first sign of bleeding, followed by hypotension.
Which is more common, Dhruv, diverticular disease or vascular ectasia or
Di-
angiodysplasia?
So diverticular disease is much more common than vascular ectasias, sir.
And why you keep on putting angiodysplasia and vascular
Sir,
ectasia as your first diagnosis?
sir,
So he
because
cannot
divert-
manipulate now the slides. Actually, the slides have been
Sure,
made
sure,
previously, I
sure,
think.
sure.
diverticular diseases usually will have massive bleeding. They'll not present with small amounts of blood, but angiodysplasias will have small intermittent bleeds. So that was the only reasoning. But diverticular disease is much more common than angiodysplasia.
So what is the difference between vascular ectasia and angiodysplasia?
Sir, this is synonyms only, sir. Not no much difference, sir. I couldn't find, sir. It's same terms only, sir. Ectasia, angiodysplasia. It's used interchangeably, sir.
Is it?
Uh,
Yeah.
sir, most
And you said something about intestinal tuberculosis. So
yes,
please elaborate on that. How would you actually defend intestinal tuberculosis apart from the patient being from Jharkhand and from maybe from a lower socioeconomic strata? So what are you missing out in the history and the examination? You never told us about the peripheral lymphadenopathy.
sir, there is no lymphadenopathy, sir, in the patient, sir. No peripheral lymphadenopathy.
So since your tuberculosis is your differential, please tell us about the lymphadenopathy. Where would you inspect the lymphadenopathy in the general physical examination?
Cervical lymphadenopathy, sir, is quite common in tuberculosis, and maybe then axillary or inguinal if it's a disseminated Cox case, but cervical lymphadenopathy will be quite common, sir.
How common you get bleeding in tuberculosis of the colon?
Sir, it is rare, sir. Mostly patients will present either with obstruction, mostly with obstruction-like symptoms only. These
Mhm.
patients usually present with obstruction, subacute intestinal obstruction. Bleeding is
Mhm.
quite rare in tuberculosis.
So, that's what I'm saying. You keep on putting rarest of the rare causes first.
Anything in the respiratory examination whereby you can actually defend tuberculosis?
So he is having normal vesicular breath sound, sir. There is no other suggestive findings, but if uh, no, sir, if the cavities will sound different. I have no experience, sir, of auscultation for tuberculosis chest, sir. So there might be some findings that I'm not aware of it, sir.
So in abdominal evaluation, in
Yes,
a intermittent bleed of a person of a long duration, what
yes.
else would you like to check?
Especially, I
Well,
would like to know on background of somebody who is alcoholic, because we have put a differential diagnosis lower down. So sir wants to know that whether your abdominal examination, you have missed some more findings.
Sir, his abdominal findings, his umbilicus was central. There were no vascular lesions on the abdomen, uh, no visible vascular lesions on the abdomen. The liver was also normal size, no ascites in the examination, and patient was anictric also. But still, because he was an alcoholic, so I had kept this diagnosis that maybe there's some underlying chronic liver disease component to it, or maybe something related to chronic pancreatitis causing venous thrombosis, splenic vein or IMV thrombosis in this patient, leading to this presentation. But this was very low down on my differentials. Just because of the history of alcohol intake for a long time, I had kept this as a differential.
Dhruv, shall we go for investigation? There aren't many positive clinical findings.
Yes,
So,
sir.
so that we get more time on discussion. Yeah.
Yes, sir.
Okay.
Sir, I'll like to review the previous investigations done around 1 month back, the HBPCV report and the report of the endoscopy and colonoscopy reports of the patient.
Yeah.
So just a comment in between. Why didn't you ever consider an upper GI bleed?
Sir, upper GI bleed usually will present with
No,
melena. Yes.
please listen to me.
Yes.
Before you just are concentrating maybe on the large bowel predominantly, and
Yes.
small bowel, you may have missed out in your differentials also, apart from tuberculosis. IBD may be one. Apart
Yes.
from that, you are saying something about the upper GI bleed in terms of a long intermittent with the background history of alcoholism.
Yes, sir.
So wouldn't you ever consider in your differential, even in your lower differentials?
Sir, because for 10 years, if he's having CLD, there would have been some other signs of decompensation also. So that is why I kept it just lower down as a last possibility, because he's
So
had no
Dhruv,
other
the
decompensation.
whole idea over here is that your differential needs to really improve. I
Yes.
mean, it is kind of, maybe not very correct in the sequence, as well as including many things which should be there.
Yes, sir.
Please continue.
Okay. His hemoglobin was 12.6, counts were 8,100, platelet was 1.6 lakhs at the time. So was this pre-transfusion or post-transfusion? But still, there doesn't seem any explanation for the transfusion he was given, if this was his CBC at that time of presentation. And I'd like to know if any other investigations were done at that time and the endoscopy and colonoscopy report of that time. His bilirubins are normal, SGOT, PT are slightly elevated, but otherwise uh, everything seems within normal. I mean, albumin and PTINR are within normal range. Serum electrolytes and urea, creatinine were also normal at that time. The esophagus linear erosions at lower end, a normal stomach, few small superficial clean based ulcers, and D2 is normal. In the rectum, there are few polyps, largest 8 by 8 mm, and sigmoid multiple polyps are there. Descending colon, multiple polyps with large polypoidal lesion 3 by 3 centimeter. And transverse colon, few polyps, ascending colon, multiple polyps, cecum, multiple polyps, and ileum was normal.
Can I stop you here, Dhruv?
Yes, sir.
In a descending colon, it says JNet 2B and 3. What does that mean?
Sir, I don't know, sir. I'll have to read about it, sir. Right.
And what do you think it would be?
Sir, maybe the malignant potential of the polyp on the basis of its
This
appearance.
is Japanese NBI expert team classification. And any surgeon who does it, and if you got a NBI with you, they look at vessel pattern and surface pattern. And one is most likely histology then you make. In type A, normally it's hyperplastic. Type 2A is polyps, which is more likely adenoma. Type 3, they will think about high grade dysplasia or cancer. Type 3 is a cancer. So, once it's there, so somebody who has done a colonoscopy has done a good colonoscopy. So
Yes, sir.
that suppose if your biopsy comes out negative, clinically, if it is 2B or 3, you need to repeat the biopsy, okay?
Okay, sir. Okay, sir.
So this is what you should know. And this is very commonly used nowadays. Okay.
Yes, sir. Yes, sir.
And what other thing is important? Because in this colonoscopy, I think multiple polyps, isn't it?
Yes, sir.
So, what are the other important things
Mm, mm.
which will sort of make you change your treatment plan or what
The
you want to do?
number of polyps in the rectum is important, in the largest size of the rectal polyp if we are considering
Why
for
the number of polyps in rectum is important and in what kind of patient is important?
in a patient with multiple polyposis, if we
Yeah.
planning to preserve the rectum,
Mm-hmm.
patient to offer patient good quality of life, we need to consider the number of polyps in the rectum and the size of the largest polyp to decide if he can be managed on surveillance polypectomies or not for the long term, or do we need to immediately remove the rectum also to decrease his risk for any malignancy.
So that is why, the number of polyps in the rectum are important, whether you have less than 10 polyps in the rectum or more than 10 polyps. And it's very, very important because when I was in UK, a lot of patients had a polyposis and they were present to us pretty young. And if it is a young female, uh,
Yes, sir.
for fertility reason, this is what is very important. And there has been quite a few studies which has said that, if you got just 5 rectal polyp, chances of polyp coming back in the rectum is less. But if you got say more than 10 polyps, chances of having a polyposis coming back again is more than 50%. See, you are not going to be super specialist. So these are the clinical thing you should know. Okay.
Yes. Yes.
Because if it is written JNET, at your stage, you are expected to know what JNET means. And the colonoscopy also, because further tests which you are going to do in this particular patient in a ideal circumstances, that also makes a difference. Okay.
Yes, sir.
Okay. Carry on.
So now I like to see his current laboratory value, current labs, his CBC on presentation and his labs currently.
The CBC and RFTs even earlier were the current ones.
Oh, okay. I like to get an ultrasound of the abdomen for this patient to see if he is having some metastatic disease or not in the presence of these polyposis, if any one of it has turned malignant and there are some mets in this case or not. So a USG abdomen for the patient. Liver is normal in echo texture and no IHBR CBD. Gallbladder is also normal. Spleen, pancreas is normal. The ultrasound examination seems to be normal only. So next I'll like to get CT done for the, I'd like to review the biopsy reports of this patient, or the biopsies which were obtained. Large descending colon polypoidal lesion, well to moderately differentiated adenocarcinoma has been seen. Okay. And any information about the rectal polyps, if they were biopsied or not at that time? Tubular adenoma with low-grade dysplasia. Okay. So I'll like to do a CCT, contrast enhanced CT abdomen and thorax for this patient to stage the disease, stage the malignancy, and also get his tumor markers CEA and CA19-9 this time.
Bro, now you have found out that he's got a polyposis disease.
Yes, sir.
What are the specific things you will like to revisit in your upper GI endoscopy?
Sir,
What are the things you will look for?
Sir, if there are any polyps in
Suppose
the-
if you have done a colonoscopy first and then doing a upper GI,
Yes.
what specific, I'm talking about what specific thing and what is the thing you will definitely do?
Sir, I'll look for any hyperplastic polyps in the stomach or duodenum at this time.
Mhm.
Also, I'd like to do a side viewing endoscopy to see if there's any periampullary lesion in this patient or
Yeah.
not.
So that is what is important, side view endoscopy to rule out any periampullary tumor. And gastric fundal polyps are normally benign, and
Yes, sir.
duodenal polyps are generally precancerous. Okay, so these are the things you should remember. Okay.
Yes, sir. Yes, sir.
So, Dhruv, you said that you would like to stage the disease. Why do you want to stage the disease at this juncture?
Sir,
The largest polyp is around, say, a centimeter. Most of the polyps are less than 1 centimeter. So,
yes,
what gives you the impression that you want to stage the disease?
just if any other meds are being missed or not, just wanted to be sure about that. Otherwise,
Any other findings you would like to pick up on CT on the background of this polyposis?
it will give me a better idea of the state of the periampullary.
Sometimes they have concurrent small desmoids. A bigger desmoid might be visible on your abdominal examination, but sometimes they have multiple small desmoids.
Yes, yes, ma'am.
And also, sometimes even the large desmoid you won't be able to examine. So you want to see whether the desmoid is present or not. If it is present, what is the size and how many numbers are there? And whether it's close to the mesentery of the small bowel, where exactly is the location of desmoid, okay?
Yes, yes.
And besides the CT scan, anything else you would, let's go for the CT scan first, then I'll talk, yeah.
Yes, yes. In the HRCT thorax, the lung fields appear clear and there seems to be no lesions in the lung fields, bilateral. There are no lesions in the bilateral lung fields, maybe some emphysematous changes in the peripheries, but no significant finding. And on the CT whole abdomen, I don't have the access to plain films. These are fast films, the CCT of whole body. The brain appears fine, no lesions in the brain. No, sir. The lung fields are clear. There are no lesions seen till now in the lung fields. And the liver, the margins are fine. The liver appears normal. There are no lesions in the liver and no changes of CLD also are visible in this liver. On the examination, the stomach is clear. There are no lesions in the stomach or the duodenum also. The duodenum also looks fine, and the pancreas also looks fine grossly. There are no lesions. Maybe prominent PD is there, but otherwise there doesn't seem any lesion in the pancreas also. For the colon, the small bowel, there are no visible lesions in the small bowel. And now for the colon, the The transverse colon, the walls are thin. There is maybe some lesion or some stool retention. There is some thickening seen here in the ascending colon. In the transverse colon, it seems fine. There are no obvious lesions in the transverse colon. And in the descending colon, there is some thickening near the splenic flexure, and otherwise there's a lesion here also in the descending colon, and then nodes, there don't seem to be any suspicious enlarged lymph nodes seen. And for the rectum also looks fine. In the rectum also, there is not much disease visible, and the sigmoid also looks clear. Yes, sir.
So, Dhruv, you said that you wanted a whole body CT scan or a CT scan. What additional information did you have from this CT scan? What I thought that you would be doing it for staging the disease, as you said,
Yes,
that
sir.
you would be concerned about the lymph nodal involvement and every other thing.
Yes.
What would be the lymph nodal involvement, or what would be the expected lymph nodal involvement, whereby the tumor size or the polyp size is a very small size of less than a centimeter? And most of them are dysplasias, only one adenocarcinoma you mentioned.
Yes, sir.
So what additional information did you want from the CT scan, the whole body CT scan?
Any desmoids, like I'm told, and if any periampullary malignancy is developing or not, or if there are some mets which have originated. But yes, sir. Nodes, I couldn't find any lymph nodes in this patient.
So you could have done without a CT scan in this scenario, or there is a protocol to do the CT scan?
There is a protocol. It should be done, sir. Ideally, I feel sure.
The CT scan of brain and
I told only a thorax and abdomen only, sir. Not for the brain. CT scan of thorax and abdomen only.
So we would be worried about lymph nodes. If I see correctly, please go to the previous abdominal side. Just adjacent to the liver, there's a small amount of free fluid, if I believe, if it's not fat, because it is not very well shown over here. Would you be concerned about a bit of ascites?
Yes, sir. If there is some ascites, there are chances that it could be there's some peritoneal seeding in this case, and there is some malignant ascites. There is
So
some
on CT scan, how do you see the peritoneal seeding, or what are the other ancillary signs which may actually suggest that there is some kind of a peritoneal involvement or some kind of an involvement which is more than the initial tumor?
There can be presence of ascites, sir, and the omentum usually becomes quite thickened, and the omentum is caked. So it will be visible separately. The omentum seems with the stranding, and becomes quite prominent if there's an omental seeding. Yes, sir. Usually it is quite difficult to pick up peritoneal mets from a CT scan. Otherwise, ascites and some omental thickening, if it is there.
So you have done a CT scan for lymph nodes. That is
Yes,
what
sir.
you believe. So, okay. Apart from that, any other thing which you want to know from the CT scan, apart from your periampullary, which you have already seen through the side wing endoscopy, as you said? You've
Yes.
already done an ultrasound, which is actually showing a normal liver, nearly normal. You did not expect anything from the CT scan. What additional information did you want from the CT scan?
Maybe the presence of desmoid tumors, if they could have been missed. And
Desmoid, maybe more than a centimeter or two, would be actually seen on an ultrasound, which was normal.
okay, sir.
And what percentage of patients do have desmoid? That is also there. But I just wanted to know that why did you do the CT scan? in addition to the existing investigation? What additional information did you want to perceive or expect to get from it?
Just
Dhruv,
did
any
a cross-sectional imaging, and sir, ultrasound is still operator dependent. So just for an objective indication of the findings, sir, CT scan.
And please.
And very importantly, you have a patient who's already nearing 60 years of age,
Yes, ma'am.
having a lesion which is malignant, already proven, and CT is very likely to this patient. You did not pick up anything, but it could have picked up in any other patient. The protocol, you were supposed to do it, I believe. Because you may have many of these patients by the age of 60 years. It depends on what kind of polyposis disease it was. It doesn't look like FAP. They are not hundreds of lesions, but still they tend to be when you remove a specimen, you tend to find 3 or 4 more sites of malignancy on detailed histopathological examination. This is what we usually come across in our practice in elder patients.
I think Dhruv, you need to
Yeah.
clear about, clear in your mind, you need to have a clarity. Like in this patient, why you need a CT scan. Obviously, you have mentioned desmoid. You want to rule out any metastasis, and you want to do the local staging where the tumor is. That is the one which you didn't mention. Why it is important? Because if it's a CT scan, say stage 1, 2, 3, it's fine. But then if it is 4B, you may need or consider, neoadjuvant first.
Yes, sir.
So, you need to have a clarity in your mind. So you were looking for a local staging and distant staging, and you want to exclude the desmoid. Okay?
Yes, sir. Yes, sir.
Yeah, you want to, because it's been there long, patient is 58-year-old. Normally, 90% of the patient who's got a polyposis will develop a cancer at the age of 40. So, you need to give why you are doing it. Now, when Dr. Pandey is asking why you are doing a CT scan, you are thinking, it's not a thought process, boom, 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 why you are doing it. That's
Yes.
what it should be.
Yes, sir.
Okay.
Apart from that, I think that your diagnosis is essentially made only on colonoscopy. Apart from that, you have findings on the upper GI scopy. You also have in your differential multiple things which you wanted to rule out. So all these things would be actually seen on the CT scan. You can actually defend the CT scan apart from the staging for the rest of the things also. And
Yes.
apart from that, you need to be very clear that now you are talking about malignancy. It was never there in your clinical scenario. One investigation which has changed your entire course of, or rather discourse, is predominantly the colonoscopy. So,
Yes, sir.
what do you think? If you see it as a polyposis, what kind of polyposis are we looking at? Firstly, you have to explain. And what other things are to be seen on the CT scan in retrospect also to rule out any other things which are usually associated with the polyposis syndromes?
Okay. So, in this patient, the polyposis may be an attenuated form of FAP. In this case, because of the late presentation, no family history, and we have to rule out for the presence of desmoid tumors and the cerebral cerebral lesions, if they can be vascular lesions associated. These things have to be ruled out. And
So that is how you justify that you did a CT scan brain. Maybe for the protocol may be different in different institutions, but you have all these associated problems whereby you can actually evaluate with the complete evaluation with the CT scan of the whole body. Okay.
What other evaluation you will do? Will you do the genetic testing at some stage? Family testing?
Sir, family member.
Family history in
Uh,
detail now.
Yes, sir. I'd like to review the family history if any of the parents had a malignancy or not. If any siblings is having malignancy, I'd like to screen his siblings as well as his children if there are, so to see if they are having any risk for developing malignancy. So,
And what genetic testing you will do?
genetic testing, sir, after establishing if there's a family, then maybe for FAP we can check if there is any uh, lesion.
Will you just do the APC testing or will you do APC and MUTYS testing or
MUTHY.
or MMR gene testing? What gene testing you will do, Dhruv, in this particular case? I'm
Sir,
just talking about this case.
Yes, sir. MUTYH testing, sir, likely, and
You will do.
APC testing also, sir, maybe if it's an attenuated.
See,
Oh,
that is where, Dhruv, it's important to read.
yes, sir.
How many polyps this patient has got?
Less than 100 only, sir. Maybe
Less than 100 or more than 100?
less than 100 only, sir.
Are you sure it's less than 100?
It's a not.
See, if it is 1 to 100 polyp, you do APC and MUTYH testing.
Yes, sir.
If it is more than 100 or say started with, then there is no point doing MUTYS testing. Okay.
Yes, sir.
And if it is just few polyps, then you do MMR gene testing.
Yes, sir.
Besides your immunohistochemistry, that's what I'm saying. You need to know.
Yes, sir.
If the whole colon is studied, then you just do APC. Okay.
Yes, sir.
So what's your plan now? You got everything now. You
Yes,
got
sir.
a colonoscopy, you got a endoscopy, you got a CT scan. What you will do for this patient and why? You
Sir,
need to justify.
I'll like to ask the patient and know if he wants to preserve his rectum or not. At age 60, his family is almost completed, and but the frequency of stools, if we remove the rectum, also will be high. So if he's willing for surveillance, but less because he's from a periphery, so there are chances he might not come
In
for.
a patient, Dhruv, in a patient who has developed a colonic cancer, will you keep the rectum? And when there is a rectal polyps there, this is not a patient who hasn't developed a cancer. See, justify. We are here. You tell me what will you do in this patient? It's not about, you need to make a recommendation. Are you going to go to the patient and say, rectum, the guy is from Jharkhand, isn't it?
Yes, sir.
Is he so well educated? Do you want to see preserve the rectum? What kind of talk you are doing, Dhruv, here? See, it's not a bookish knowledge which is important, it's the practical knowledge. And you are getting caught at all the time in all the clinical knowledge. In this patient, what will you do? What will you tell the patient you will do? Will you do single stage, 2 stage, 3 stage? What will you do?
Do a 2-stage total proctocolectomy with the pouch and a divergent stoma, and like to do a divergent stoma and reversal of the stoma in the second stage.
And why will you not do the pouch? Why will you do 3 stage?
So I'll do it in 2 stages only, sir. I'll do the pouch in the same sitting, sir, as the total proctocolectomy.
What is the advantage or disadvantage of 2 stage and a 3 stage?
So 3 stage is usually for those patients who are quite sick and will not tolerate the stress of a surgery. So to initially to stabilize those patients,
Suppose if this patient would have had a, say, T4 tumor on a CT scan, will you do 2-stage even in those patients?
no, sir, I'll not do a 2 stage. I'll do an endoleostomy for that patient, and after chemotherapy only, I like to give him a pouch.
Yeah.
He's
So
still
in this patient, if you would have carefully seen the CT scan report, there is a stranding seen in the pericolic fat where the tumor is.
yes, sir.
Did you read the report?
No, sir, I've not.
No, we all read the report. I've read the same report what you have read. Is there a doubt in your mind that this could be an advanced malignancy, may require adjuvant therapy? What are the cases in polyposis which require adjuvant chemotherapy? Tell me the.
Patient has T3 disease or like
Huh?
N positive disease or T3 disease.
Yeah.
Then he'll require adjuvant
Okay. What else?
if there are synchronous malignancies in the patient, then also
What else?
and for
If there is a lymphovascular invasion present,
yes, sir.
okay. If
Yes.
there is a T3B or stage 4 disease,
Yes, sir.
T4 disease, lymphovascular invasion, lymph node positive, and
Yes.
there is a high likelihood in this patient, why? Of his age, he is 58. On a CT scan, there is a stranding in a pericolic fat. Although it's a sub-centimeter lymph node.
Yes, sir.
So these are the things you can justify both of them. Why you will do 2-stage, why you will do 3-stage, but you need to justify.
Yes, sir.
Okay.
Yes, sir.
So why you want to?
So in this case, I'll go for a 3 stage, then give him an endoleostomy and then give him chemotherapy if the staging shows so, and then we'll proceed further. Still, and I can also offer him
You
2 stage,
know,
sir, with a pouch.
Whenever we push you, you change your plan, isn't it?
So currently, what is the scenario? What do you think the patient is having? And what, according to you, you have a sequence on the CT scan also, which can stage the tumor preoperatively. So please tell us what kind of tumor does the patient have, along with the polyposis, and what kind of polyposis does the patient have?
The tumor is stage T3 tumor, T3A, T3 tumor, sir, with maybe N plus disease. And polyposis, there are multiple polyps, but they're not so numerous. Mostly the polyps were sessile only, not pedunculated polyps. So yeah.
So apart from your counseling, your immunohistochemistry, and rest of the things which you have done, you would offer the patient surgery. You would offer the patient surgery in terms of what kind of surgery would you offer? Robotic, laparoscopic, open? What are the things which you want to do, and how would you proceed?
Sir, maybe laparoscopic surgery, sir. Robotic all quadrant surgery, total colectomy will be difficult. So laparoscopic colectomy or an open colectomy, and laparoscopic with CML and CVL and CME, sir, and with the APR, with the total mesorectal excision combined with it, sir. And adequate lymph node harvest, sir. For lymph.
So, has the patient undergone the surgery, or is he still waiting the surgery?
Patient
Do we have the information regarding?
is a patient underwent a total proctocolectomy and end ileostomy.
Total proctocolectomy and ileostomy. Okay. And we have the post-operative histopathology too?
Yes, sir.
Please tell us.
It was a pathologically PT2 and 0 tumor. 21 nodes were harvested, which were negative.
So tell us about the PT2. What is PT2?
So the tumor is invading the muscularis propria only. There is no invasion beyond the colonic wall in the tumor, sir.
What
So
information?
will you give adjuvant chemotherapy in this patient, Dhruv?
Sir, it's not needed, sir, for this patient, sir.
Are you sure? In a high risk stage 2 tumor, if there is a lymphovascular or perineural or a high grade tumor, will you give or no?
We'll give if there's a lymphovascular or perineural invasion. we'll
Yeah,
give
and
chemotherapy.
a high grade tumor also if it is poorly differentiated, isn't it?
Yes, sir.
So you need to go into the depth, although it's come out T2, but what has been done is absolutely what I would have done, okay?
Yes, sir.
Rather than creating a pouch and then regretting it later, because with the pouch you want to give patient one good chance, okay?
Yes, sir.
So any other information which you would like to know on the histopathology, which would actually corroborate your, colonoscopic findings?
The status of other polyps, sir. What was the
Okay.
of other polyps? And sir, the presence of lymphocytic invasion, if there is any lymphocytosis or the further with this.
The other polyp showed features of tubular adenoma with low-grade dysplasia.
Okay. There was no other malignancy apart from a singular lesion, as you're saying.
And Dhruv, when you go next time and create a pouch, what kind of pouch you will do? Will you do the hand sewn or stapler? Where exactly you will fire the stapler, or where has been it cut? Any idea? What is your preference? What you will do, or
Do a
what you are watching?
J pouch, sir, and in this case, hand sewn anastomosis with mucosectomy of the rectal mucosa. Okay.
What is the drawback of mucosectomy and hand sewn?
Sir, hand sewn
And what's
anastomosis.
the advantage?
Sir, the drawback is that it can stricture, sir, later, and patient might need anal dilatations further.
So
And
there is more anastomotic stricture and septic complication. There is a slightly increased risk of pouch failure, but it removes all rectal mucosa, less fear of neoplasia. Okay. And what is the advantage and disadvantage of stapler?
sir, stapler, sir, there are less chances of stenosis and pouch failure, sir. But the disadvantage is the cuff of rectal mucosa will remain, which in this case is having malignant potential, so it should be removed. The patient can't come for surveillance.
So it's a simpler approach better function, okay,
Yes, sir.
associated with slightly fewer complication, but there is a risk of development of neoplasia in the rectal cuff or anal transition zone. So
Yeah.
in my practical approach, what I do, that's where, you need to go and think how many rectal polyps are there in the rectum. If it is totally studded, then I won't. But if there is, say, 10 polyps in the rectum, I will do the stapler because long-term results are better. Okay?
Yes, sir.
What I normally do is I will cut it just above the dentate line, say about 1 centimeter above the dentate line, and that helps in the functioning. Okay?
Okay, sir.
The
Yes, sir.
control is better. Control is better.
Yes, sir.
And then what I will do is surveillance sigmoidoscopy. That's what you can do. So
Yes, sir.
everything has got a logic, Dhruv. Okay.
Yes, sir.
So when you are doing a colonoscopy, I was surprised that, on proctoscopy, because when you are doing a proctoscopy, they didn't find any polyp. They didn't find any polyp. And
Yeah.
I always do PR myself and proctoscopy myself, so that I know where exactly I need to fire the stapler. Okay.
Yes, sir.
And these are very, very, things which should do you good in a long term. Okay. In a long term.
Yes, sir.
Okay. Any other questions from any moderator or other experts we have here?
Dr. Rawat and Pandey, there are Q&A, there are two questions. Can you address those?
Yes,
Okay.
please.
So one question is, why can't we put hemorrhoids as the first DD as it's more common? I think we have already addressed it. And the other question is, the number of polyps in rectum for rectal preservation is 20 or 10.
See, regarding the rectal preservation, it depends on if it is, it depends on if it is a female and who is young, who wants to have family completed first, then I would rather like to have a polypectomy of the rectal polyp first so that I have a biopsy, histology report. If it is a low-grade dysplasia or a hyperplastic polyp, I will preserve the rectum. But if it is a high-grade dysplasia or malignancy, I will counsel accordingly. But in a patient who's got, say, rectal polyps are very few in the rectum, in a female, I would do the ileorectal anastomosis, let her complete the family, carry on doing the surveillance. We have done quite a few of those girls in UK because polyposis was common and they have a genetic testing also, and they are routinely, suppose if any of the family member have a polyposis disease, they will start having a colonoscopy at the age of 16 and they will plan accordingly. So you need to discuss with the patient, tell them pros and cons, and that's what it is.
So, sir, there is another question which is, I think, in continuation, that the diagnosis is basically of polyposis, but it is not fitting into familial adenomatous polyposis or attenuated in scenario of more than 100 polyps. Can it be explained by other polyposis syndromes or somatic mutations?
See, it could be. That is the reason what I was talking about is if it is 1 to 100 polyp, it could be MUTYH thing as well. So unless and until we do the testing, gene testing, then only we will come to know.
So immunohistochemistry and rest of the paraphernalia needs to be evaluated, and it has to be seen in totality with the family history and the familial evaluation too.
Yeah.
So, Dr.
And
Pradeep,
sometimes, you can have a look at the retina also, send the patient to the ophthalmologist if they have got a pigmentation there. It is a APC. That is a easier thing. And then in such kind of, I think histology will tell us how many polyps are there. And I think in this patient, it'll be more than 100. It'll be more than 100 because polyposis all around. I think that is what the colonoscopy was there. And if it is 1 to 10, it's a different kind of a thing because we use the different term for that. And if it is more than 100, then it's a polyposis syndrome.
so I would hand over it to Dr. Pradeep now. Professor
So,
Pradeep, please.
thank you. Any other comments from the faculty before we wind up?
Morning. Good morning, Pradeep.
Good morning, sir.
So, Vicky Kapoor here. I would have preferred if the presenting complaint, you should have said that here is a patient who has bleeding per rectum for 10 years, which has increased in amount of frequency or whatever for last 45 days. Because many examiners stop you at the presenting complaint stage only and ask you, what do you think? So unless you give the total duration, the discussion would not be proper. I don't think you should make a clinical diagnosis of angiodysplasia. These are certain entities which are diagnosed only on radiology. Similarly, making a diagnosis of IgG4 cholangiopathy or autoimmune pancreatitis or xanthogranulomatous cholecystitis, these are all histological diagnoses. The clinical diagnosis is always something else. If there is a patient who has a long history and there is a recent change or alteration or new symptom, the most important thing which you have to think is that there is a benign disease to begin with which has turned malignant. For example, choledochal cyst having recurrent episodes of cholangitis and now there is a cholangiocarcinoma. For example, chronic pancreatitis and now there is a superimposed malignancy. IBD and malignancy, polyposis, malignancy. Now here, in this case, making a clinical diagnosis of IBD would be a little difficult because there is no history of diarrhea. Making a clinical diagnosis of IBD, especially when the duration is 10 years without any history of diarrhea and passage of mucus and pus in the stool is not likely. So in my opinion, the most probable clinical diagnosis in a patient like this would be an underlying polyp disease which has turned malignant. When you were asked about lymph nodes, this I have said earlier also, if your differential diagnosis includes an intra-abdominal malignancy, you must specifically mention left supraclavicular lymphadenopathy. If your differential diagnosis includes tuberculosis, you should specifically mention upper deep cervical or jugulodigastric nodes, which are the commonest involved in tuberculosis. If your differential diagnosis is going to include lymphoma, you have to talk of all lymph nodes, cervical, axillary, inguinal. Now, when you were asked about abdominal tuberculosis, the diseases which are more common with us, gallbladder cancer, abdominal tuberculosis, amoebic liver abscess, hydatid disease, ascariasis, you have to know everything. You should have said the commonest presentation of abdominal or gastrointestinal tuberculosis is with subacute intestinal obstruction, but ulcerative type of abdominal tuberculosis can present with bleeding per rectum. You should use the opportunity of a question being asked to you to show your knowledge. Now, on colonoscopy, if you see multiple polyps, the most important thing is to know the number of polyps. I don't know whether it was mentioned in the colonoscopy report or not, but the endoscopist has to mention whether there are more than 100 or less than. I'm sure they don't count each and every polyp, but they make an approximate guess as to there are more than 100 or less than 100 polyps, because that changes the diagnosis, as Dr. Rawat said. You used the term multiple polyposis. That is not correct. Polyposis itself means that there are multiple polyps. So there is no entity called multiple polyposis. It is polyp or polyposis. You said ultrasound before you looked at the biopsy because you wanted to look at metastasis, but till that time there is no suspicion of malignancy. So you should have looked at the biopsy first If it shows malignancy, then yes, metastatic workup is required, which I may agree that first an ultrasound and then probably a CT scan. If you have diagnosed polyposis and especially FAP, then upper GI endoscopy is a must. You have to see whether there are polyps and especially any malignancy in the periampullary area. So all patients with FAP should have an upper GI endoscopy. And on the reverse, if you see a young patient with periampullary carcinoma, you should get a sigmoidoscopy or a limited colonoscopy done to rule out polypotic disease. CT scan for colorectal cancer, especially colonic cancer, usually doesn't change your plan of management because nothing would take you away from removing the tumor. The exceptions would be a locally advanced disease, which is especially infiltrating the posterior parietes, but then probably a clinical lump would be palpable. Exception could be bilateral studded multiple liver metastasis and an elderly or a high comorbid, multiple comorbidity, high risk patient where you may not operate, especially if the colonic primary is not causing obstruction or bleeding. And for that also now there are non-surgical methods. So lymph nodal involvement doesn't take you away from resection. Neoadjuvant treatment in colon is much less frequently required and used as compared to rectum. So you should be able to say that what you are looking for on CT scan and in colonic or rectal malignancy, depending on the location, both ultrasound and CT, you have to mention, of course, in a large tumor, any evidence of hydroureter or hydronephrosis. You said CA19-9. I don't know whether in colorectal malignancy, as a routine, you would do CA19-9. And last is a very frequently misused term, total proctocolectomy. Total proctocolectomy means that you are removing the entire rectum, including the sphincter, and the patient is ending with a terminal ileostomy. When you do a pouch and ileal pouch anal anastomosis, IPAA, what is the correct term which should be used is restorative proctocolectomy, RPC. So there is a difference between restorative proctocolectomy and total proctocolectomy. So students, please send me a mail, vkkapoor.india@gmail.com, write rectal bleeding in the subject of the mail. I'll send you the chapter which deals with how to make a differential diagnosis of rectal bleeding. Thank you, Pradeep. Thank you.
Thank you, sir. Dr. Shastri, Dr. Supe. Dr. Shastri. You are not able to connect. Can we wind up, sir?
Yes, sir.
Yeah, thank you, Dr. Saumitra, Dr. Pandey, and Dr. Sadaf Ali and Dr. Dhruv. Thank you very much.
Thank you. Thank you.